Great. Hey everybody, so this is part two of your ABG refresher. I just wanted to talk quickly about metabolic causes for acid-base anomalies or abnormalities. So you have your metabolic alkalosis. This is where your bicarb and your pH readings are both going to be higher than normal. Um, So an example of a metabolic alkalosis would be your pH being 7.56, PCO2 being 44, which is within the normal limits, your bicarb being 36, and your PO2 being 94. So this is an example of uncompensated metabolic alkalosis. So some of the causes of metabolic alkalosis could be things like hypokalemia, hypochloremia, gastric sectioning or vomiting, excessive administration of corticosteroids or bicarbonate, and then a lot of times metabolic alkalosis can be caused by frequent diuretic use or hypovolemia. Metabolic acidosis occurs when there's a presence of other acids, which is then verified by the bicarb and the pH being lower than expected. So typically the bicarb is decreased in these situations because that bicarb acts as a buffer in the blood. So when it comes into contact with fixed acids, it gets used up to try to neutralize those acids, and then your pH decreases along with the decrease in the overall bicarbonate. So there is an example of metabolic acidosis, pH is 7.26, PCO2 within the normal range of 37, bicarb is 16. So this gives you an uncompensated metabolic acidosis. Okay, so some of the causes, the most common is going to be that lactic acidosis that often occurs, or you're going to often see in your post-resuscitation patients because they've been not oxygenating or ventilating for a period of time. You have your ketoacidosis. This is commonly seen in patients with diabetes mellitus. Just kind of a little reminder from patient assessment, those ketoacidotic patients, one of the telltale signs is usually kind of fruity smelling breath, and they'll be typically presenting with Kussmaul breathing, which is that really, really super deep and fast breathing. Aspirin overdose also can cause metabolic acidosis, renal failure, and chronic diarrhea. So acute hypoxemia is the most common cause of lactic acidosis. It is commonly associated with respiratory disorders. So you have metabolic acidosis that's caused by lactic acid. Often is going to be something that's going to further compromise the respiratory acid-base balance, because then your renal system isn't going to be able to compensate for your respiratory system. So lactic acid buildup happens when oxygenation is inadequate to meet that tissue metabolism. That causes that anaerobic metabolism, and the lactic acid is formed. So here's an example down below of kind of again, metabolic acidosis patient, ABG. So 7.21, which is low. Your PCO2 is within normal limits, and your bicarb is really low, along with a low PaO2. So how we usually determine whether metabolic acidosis is due to these things like lactic acidosis or fixed acids, increase in fixed acids, we are going to evaluate the patient's anion gap. Okay, so the anion gap is calculated by adding together all of the positive anions, which there's only one, which is sodium, and then subtracting the anion or the negative anions, so which is your chloride and your bicarbonate. Okay, so 140 minus 105 plus 24 is 140 minus 129, which is an anion gap of 11. So the normal range is typically 9 to 14. Anything greater than 14 represents metabolic acidosis. So clinically, when a patient demonstrates that metabolic acidosis and an increased anion gap, you assume that the source of the acidosis is from fixed acids. So you need to identify that fixed acid and treat it appropriately. So metabolic acidosis, as an example, caused by that lactic acids, requires oxygen therapy to reduce the accumulated lactic acids and improve the acid-base balance. If the metabolic acidosis is because of ketone acids from, ketoacidosis, that's going to require insulin therapy to fix it and correct it. Right. So if your metabolic acidosis is caused by like a loss of bicarb, that does not cause the anion gap to increase. This can be because as the bicarb decreases, chloride usually increases to maintain that gap. So an example of this would be like in cases of like renal disease or severe diarrhea, you might see the bicarb decreasing, but your chloride concentrations increase. So this is typically called hyperchloremic metabolic acidosis. So it's just trying to keep that balance of that gap. Okay, so to talk about the last couple slides are just talking about assessing oxygenation off of the ABGs. Remember, it's very easy to focus when you're looking at ABGs and just focusing primarily on that acid-base balance, but we get a lot of information about oxygenation there as well. So there is going to be some age-based acceptable PaO2 ranges that you might encounter. So typically we talk about normal ranges being 80 to 100, but as people age, their PaO2 concentration will just naturally decrease, okay? So if your age is over 70, you can be anything greater than 70 torr or millimeters of mercury is adequate. If your age is over 80, anything greater than 60 is adequate. You don't get to see a lot of these over 90-year-olds, but anything greater than 50 for a 90-year-old is adequate. Okay. Remembering back, we talked about the oxygen hemoglobin dissociation curve. So the amount of oxygen that is going to be bound to your hemoglobin is going to be related to the partial pressure of oxygen in your body. I've talked a million times about how most of the oxygen that's transported throughout our body is bound to hemoglobin, but in order to get that oxygen and the hemoglobin to kind of marry up and get transported throughout the body, there has to be a really high concentration of O2 in the blood. So there has to be a high enough PaO2 level to have that hemoglobin bind with oxygen. And this relationship is called your oxygen hemoglobin dissociation curve. So it is S-shaped. So typically the steep part of the curve is from 10 to 60. Okay, and then you're going to plateau off in the beginning and then at the top. So if you think about it as it takes a little bit for, it takes about 10 millimeters of mercury of oxygen dissolved in the plasma before that oxygen is going to start binding with the hemoglobin. Once it starts binding, it's going to keep binding, keep binding, keep binding as we increase our concentration of O2 up to about 60 torr. And then at this point, you're about, let's go across here, 90% saturated. 92% saturated. So at that point, you're going to start kind of plateauing off because most of the hemoglobin has oxygen attached to it at that point. Okay, so we talked also about how this curve can shift to the left or right in certain circumstances. So if you think about it, in the lungs, we really, 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 really want that hemoglobin to have a good affinity for the oxygen and to kind of be held on to the oxygen really well, hold on to the oxygen molecules really well. But when we get to the tissue levels, we want that hemoglobin to more readily release it. Okay, so that's why we have this shift. So in the lungs, this shift is going to be more to the left. In the tissues, the environment of the tissues is going to be shifted more to the right, and that is because of a couple of these factors. So factors that shift things to the left are increased pH. So if you think about the lungs, you're going to have a higher pH level in the lungs because you're releasing all of that CO2. You have a decreased temperature, decreased PCO2 levels. This is also some things that can shift it to the left are this BPPG hormone that pregnant ladies have, and fetal hemoglobin. Also, carbon monoxide, carboxyhemoglobin also causes it to shift to the left, so it has a high affinity for that oxygen. Shifts to the right is a decrease in pH. So as the pH drops, which happens at the tissue because there's so much more CO2 entering the blood at that tissue level. Increase in temp, usually your tissues, because of the metabolism that's happening there, has a little bit higher of a temperature. And then an increase in DPG, which is also a hormone. All right, so this is just kind of a picture of that, explaining the kind of the same thing. So right shifts loading of oxygen. And then left shifts the loading of right shifts loading of oxygen in the lungs. Oh man, I got this slide as a typo too. Hold on. Okay, so ignore the title up here on the top here. So normally PaO2 of 60, that usually means that your hemoglobin is bound at about 90% saturations. Okay, so this next slide is a picture of the left shift of the loading of the oxygen in the lungs. So this means that your hemoglobin, because it shifted to the left, it means your hemoglobin has a higher affinity for that oxygen. That oxygen is going to want to bind to that hemoglobin, attach to that hemoglobin, and the hemoglobin is not going to want to let go of those molecules. When we get to the tissue level, the opposite happens, where the hemoglobin doesn't have as strong of affinity to the oxygen. The oxygen then is more readily unbound and then moves into the tissues from the blood. Okay, so let's analyze some of these ABGs. Okay, so this ABG here is 7.5, PCO2 of 29, 75 for my PaO2, and 23 for my bicarb. So if I do my tic-tac-toe, my pH is high, so it's going to go on the alkalotic side. My PCO2 is low, so that also is alkalotic. Okay, my bicarb is normal, so that guy goes right in the middle. Okay, so because the pH is abnormal, I know I'm either partially compensated or uncompensated. Because I do have one value within the normal range, I know that then I'm uncompensated. So I would say I'm uncompensated alkalosis. And since the CO2 is in that alkalotic column, I'm uncompensated respiratory alkalosis. My PaO2 is 75, which puts me in mild, given what we've been given, mild hypoxemia. So again, like I said, now you should know enough about ABGs and start thinking about correcting things for age a little bit. So if you have a super old patient given in a scenario, or remember if you have a COPD patient in a scenario, you might tolerate oxygen levels in that mild hypoxemic range without feeling the necessity to treat. Here's another question to go through. So mechanical ventilation was initiated for a patient after which the PaCO2 decreased from 53 to 40. A respiratory therapist should expect which of the following will increase. So when you're asked questions like this, okay, you can kind of draw out your tic-tac-toe a little bit. So if I initiated mechanical ventilation for a patient, and originally their PCO2 was high. It was in the 53. So that would have been a PCO2 over here in the acidotic column. Okay. I don't know anything else about this patient at all, right? But I know that when my PCO2 is acidotic, my pH tends to be acidotic. If I don't know anything about the bicarb, which I don't. So all I know is that my CO2 is acidotic. If I'm thinking about my pH in relationship to my CO2, that will also be acidotic, meaning my pH is low, my CO2 is high. Okay? So if my CO2 all of a sudden drops to 40, that puts my CO2, moves my CO2 over into the normal range. Okay, the question's asking you if a respiratory therapist should expect which of the following will increase. So would I expect, if my CO2 level is dropping, I would expect, I don't have enough information to think that my bicarb would be dropping as well. But typically if my CO2 drops, my bicarb drops. It doesn't do the opposite. My pH though, if my CO2 drops, my pH, in order for my pH to move back over here, my pH would have to increase. So that looks like a really good answer. Your PeCO2 correlates with your PaCO2. So if one drops, the other should drop. And then my tidal volume, dead space tidal volume ratio, this is just a distractor. Okay, so that answer would be B. Oops. So according to CLIA standards, quality control must be performed for blood gas analyzers every. So this is just something to kind of think about from our discussion about. So for this one, this does look like, oops, sorry. This does look like, sorry. There we go. This looks like a good answer because, you think about it, you're like, oh yeah, I'd want to do quality control checks on equipment every 24 hours. But for CLIA licensing, you should actually be selecting every 8 hours. Remember, a lot of decisions get made off of blood results, and diagnostic testing is through blood. So most regulations are pretty stringent to make sure that these don't go out of range, because if you think about it, just a little bit of out of range could really affect your decision making. So, if your PCO2 on your patient really is, 40, 5, but it's reading on the machine 55. That's only 10 difference, but that could really impact what decisions you're making for your patient. So that's why CLIA licensing or CLIA standards are so kind of strict, and you want to do QC testing every 8 hours. Oops. So which of the following values for arterial carbon dioxide tension is consistent with alveoli hyperventilation? And again, I'm asking you this question just to think of things in a bunch of different ways, right? So let's pick this question apart. So we have that what I'm asking you for is alveoli. Oops, good Lord. I need to get my drawing thing to work. Alveolar hyperventilation. So what is the acid-base imbalance associated with alveolar hyperventilation? So I'm hyperventilating, meaning I'm breathing out more CO2 than my body is necessarily producing. Okay, so I'm exhaling more CO2 than my body needs me to be. So my PaCO2 value would be low. Okay, so less than 35. Okay, so then I look over here and I look at the values here and I see that there is only one value there that is less than 35. Okay, so I just wanted to give you a couple examples that I've come across of how the MBRC asks these questions related to ABGs. To give you again a little bit of a refresher, reminder about some of the things to do with ABG values. So I hope this helps. Let me know if you have any questions.